we want to improve your quality of life. And that might be decreasing the number of UTIs, but also might be decreasing the severity and improving the response of the UTIs to standard treatment.
Today, I'm speaking with Bob Yang, a consultant urologist based at the Royal Berkshire Hospital and a partner at the Forbury Clinic. As the clinical lead for functional urology in Berkshire, he specialises in the treatment of complex urinary tract infections, pelvic floor rejuvenation, and both female and male incontinence. Thanks for taking the time to share your expertise with our global community.
Hi, Melissa. Thank you for the invite. It's my pleasure to be here.
We have a lot of questions because one of your specialties is Uromune, the UTI vaccine. But before we jump into those, I'd love to hear about your background and how you came to be working in this space.
Of course. So yes, Melissa, thank you for the introduction. My name is Bob Yang. I'm based at Royal Berkshire in the NHS and the Forbury Clinic privately in Berkshire, but our reach is pretty international, which is great. How I got into this space is interesting. UTIs, I'm preaching to the converted here. UTIs have always been an absolutely under-resourced, underfunded, and under-researched area of medicine. You know, we every 5 minutes it feels like a new treatment for benign prostate hypertrophy will come along the grapevine. But yet somehow when it comes to actual UTIs, it is still using ancient technology in the modern era. And so when I was still in my training with Steve Foley, who was my mentor then, he and I came across this new treatment, Uromune, and we were already starting to think, look, we had all these patients in our clinic who were desperate for new therapies, We were one of the earliest adopters of bladder installation therapies in Berkshire, which is great. In fact, we currently use over £500,000 worth on the NHS each year. But even then, a small cohort, it didn't work for. So what do we do then? We were desperate to find new solutions. And so when we saw this data coming out from Spain, we thought, well, come on, we can't give it all to the Spanish, can we? We got to get some for the UK. And so from that perspective, he and I together brought it over to the UK, tried on a few patients. We're very careful in our implementation and follow-up for these patients to ensure we had good governance, but also to make sure the safety of this sort of off-license medication is there. And it's really spiraled on from there. From there, we've really gone bigger and better, trying out new ways to really get over this really difficult problem, which, as it happens, affects so many people, more than prostate cancer, as it happens. So this is really where I got interested in, and I sort of kept that interest going forward ever since.
It was interesting because I've known for quite a while that you use Uromune in your practice, but I didn't realize that you and Steve were the first clinicians to bring it to the UK until I started looking at what had happened with Uromune in the UK. So I have a lot of questions about that, and I think we should just jump straight into them because you've given that great background. For people who haven't heard of Uromune or are unaware of how it works, can you tell us about what is happening immunologically speaking when someone uses it?
Yeah, absolutely. So the understanding of UTIs and the immunology behind it has shifted massively. So I have two young girls. They bring back awful diseases from their nurseries, infect the whole family, and we go, God, what doesn't kill them will make them stronger. And we can say that through sweaty, tear-stained eyes, whilst we're wiping away snot and whatever gunk was coming out of their noses. Because that is the traditional thinking about immunology behind UTIs. However, the recent data from 2020 in mice models really has shown it is the opposite. In fact, that is the basis of why people get chronic recurrent UTIs. What happens is initially your body fights it off. You have a very strong Th1, so the innate response that kills bacteria and restores everything. But over time, as you get more and more UTIs, the immune system flips to a Th2 adaptive response. And whilst in other places that is seen as the helper one, the one that's more strong, more targeted, gives you long-term protection, in the bladder, it does the opposite. All it does, it restores the lining of the bladder, the inner lining, but has no effect killing the uropathogen. So therefore, the more infections you get, the more Th2 response you get. Lo and behold, the more UTIs you get. And in fact, that's where the basis of this deep-seated infection we've been hearing about, these chronic UTIs, occur. And how many times have you had patients come and say, people keep saying, I'm making this up because we've done a cystoscopy and it looks normal. Come on, we've heard this too many times already. This is the reason, because the switch in the immunology behind it is different in the bladder
Hmm.
compared to the rest of the body. And so this is where Uromune comes in. What it does, it's a spray on the tongue for most common uropathogens, all dead bacteria, so it's not alive. And you spray on the tongue. And the tongue's immunity, the oropharyngeal, is linked to the bladder. So they actually did a study back in sort of the 2000s, and it's really, I mean, no idea how they got that through ethics. It was actually using cholera toxins. So you can imagine trying to get that through ethics these days would be a
Uh-huh.
bloody nightmare, wouldn't it? But what they did was they realized cholera toxins, you stimulate one side, you get an antibody in a distant side. And so this is where your immune comes in. If we stimulate the immune system in the oropharyngeal region, you get a very strong distant immune response in the bladder. And that
Hmm.
immune response is to flick it back to the effect where it kills the bacterium as opposed to just finding it and burying it. And that's the theory behind where Uromune came from. And it's all based upon the latest data from basically 2020 mice models.
Okay, and the vaccine itself covers 4 different bacteria. What are they and how were they chosen?
Well, see, this is really interesting, right? So you probably heard about other vaccines in the past. So you had the Eurovaxon, which was just an E. coli only vaccine. You had Solovac. You had all these sort of different types of vaccines. The difference with Uromune is it has 4 different bacteria. And why did that? Why do we need 4 different bacteria? Well, because we did these studies. The manufacturer did the studies on Uromune itself and realized you do not get a strong enough response with just one. For
Hmm.
some reason, you need to have a broad spectrum exposure to the uropathogens in order to get a very strong response. So it's E. coli, so that's the most common one. 95% of all pathogens, uropathogen is going to be that. But you also need Klebsiella and you also need some Proteus. So these are all what we call gram-negative bacteria. So they share a very common lipopolysaccharide outer layer. So they look very similar in terms of the outer layer, though they are different. But also there's Enterococcus, which is gram-positive. So,
Hmm.
it gives you a broad spectrum exposure to the bladder compared to just having one pathogen. And when we look at the animal studies and look at the immunological studies, that is why you need 4 as opposed to just one. But that goes to the other question. Well, does that mean it only covers those 4 bacteria? And that's a
Exactly.
very, very good question, isn't it? Because I've seen places where they say, well, if you don't have those 4 bacterium, we would not give you this treatment. That is wrong. I can say that right now. That is wrong. Because we know for a fact that immunity does not discriminate.
Hmm.
Your immunity will take out whatever it wants to, right? It will take out Pseudomonas, Citrobacter, anything it likes, not just those 4 bacteria.
Hmm.
So if you can stimulate your Th1 response once again and start actually expressing those interleukins that actually kill bacteria, it will give you a broad spectrum response as opposed to a targeted response, which is why I'm a big fan of using it in a variety of more complex patients where you don't get those top 4 pathogens, where you get what we call rare pathogens, and it still
Hmm.
seems to be relatively effective as well.
Well, that's interesting. And that is a question we get often from the patient community, especially because we know the limitations with standard culture might not even tell us what really is going on in the bladder. What does your long-term patient data tell you about who responds best to Uromune and who might not be a good candidate?
It's a really, really good question. So when we did our initial study over the first 12 months, we were looking at, what is it that could predict who does well in it, as well as obviously the safety profile. Well, the first thing to say is the safety profile is great. There has been so little side effects. In fact,
Hmm.
most of the time you see more side effects in placebo than you do in the real treatment group, which is fantastic. But in terms of looking deeper into what is more effective or not, well, actually, it's as you would expect. Those with more UTIs, i.e., the more complex, the more frequent, the more recurrent ones, seem to do slightly worse than the ones who maybe have 2 or 3 infections,
Hmm.
bit of a nuisance. The other one is how long they've presented for. The patient who's been there for 15, 20 years suffering with long-term antibiotics versus the patient who's come in having developed this over the last few months.
Hmm.
Obviously, you can imagine the efficacy is different. Now, we haven't been able to pin down exactly this because, unfortunately, our data is too small. We just
Hmm.
don't have the large numbers to get an exact answer. But anecdotally, I think for those in the UTI field, we all know actually those with more UTIs seem to need a longer course or more adjuvant treatment versus the ones who are, who are more basic. But also, it's about the patient itself. The elderly
Hmm.
patient with multiple comorbidities, the ones who are immunosuppressed, the ones who have a transplant, for example, a renal transplant, or even those who have adjuncts into their urinary tract, will put them at much higher risk. It doesn't mean it won't work. And I think that is the key. We know the efficacy has been really, really quite good for the
Hmm.
simple recurrent UTIs, but for the more chronic embedded ones, the efficacy is not as good. But it doesn't mean it doesn't work. And what I've really been a big fan of, and I think this is the key here, is I've been a fan of something called marginal gains. Where if
Hmm.
the Uromune, by switching the immune system and give you a benefit of, say, 30%, and then another type of therapy, for example, bladder instillation can help you for another 40, 50%. Actually, suddenly by combining the two, you get enough to get you 80% of the way there, which for a lot of our patients would be a lifesaver compared to what they're currently
Yeah.
experiencing.
And that's a really important point to make, and something that we try to touch on as well. There's rarely one thing that will help a lot of people, but there are a lot of things that might help people in some way. And
Oh,
this is one of
absolutely.
them. And a lot of patients would take a 20% improvement over nothing because the quality of life
Absolutely.
gains are so significant.
And absolutely, you're completely right about that. When we think about UTIs and treatment, it is not just, there is a tendency, I think, in medicine to say, we'll throw one tablet at you and move on to the second tablet. And it
Hmm.
goes bam, 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 very much sequentially. And all that happens, it kicks the patient down the road. And because each time you follow them up is 6 to 9 months before you can get
Yeah.
them back in clinic, they're just suffering during that time. You're absolutely right. It's about the holistic package. So, we talk about other things for the patient. There's plenty of data about vaginal estrogens,
Hmm.
restoration of that microenvironment. There's loads of data about actually, non-pharmaceutical intervention. So things like supplements actually has evidence for it. Things like
Hmm.
the diet, a change in your diet and exposure to different things can change your response to UTI. So it's about looking at the whole patient, not just throwing one somehow silver magic bullet and it'll cure the whole thing. I think that's unrealistic. We have to be very broad spectrum in our approach.
Absolutely. And we see that in the patient community every day. People who found some improvements by changing their diet or changing their supplement regime or using vaginal estrogen. There are so many ways that patients find improvements. It's the whole reason for this channel and why I'm talking to you today, because Uromune is one of those ways. And you've kind of answered this question already, but just to sort of sum up what you've been saying, for people who have a chronic UTI or an embedded infection, Uromune might be helpful, but maybe less helpful than those people who have fewer infections.
Absolutely, absolutely. And I think this is the key here. If it was a magic bullet that cures everything in the world, then that would be wonderful. But that is not realistic. That is not real life. But for those with the chronic UTIs, the embedded UTIs, in my mind and in my practice, the last resort is long-term antibiotics,
Hmm.
right? We can always go back to oral IV antibiotics, either at prophylaxis or treatment dose, depending on what regime you want to follow,
Hmm.
as a last line. That is always going to be there. But what we do know more and more now is the side effects from that can be devastating, in
Hmm.
particular, wrecking the gut microbiome, because an antibiotic is a nuclear bomb. It does not target just one area, it targets everything. And you expose it long enough, you will have more side effects. So if there's a way we could avoid antibiotics, for me, that is a win. So yes, absolutely, for those of the embedded chronic UTIs, Uromune may help, and we've had some great success in some of
Hmm.
these patients. It may only help a little bit. And for those patients, I keep saying to them, look, don't lose heart. There are other options. For example, we've been using bladder installations, not just Iaralol or the Hyacid or those gag replacement, but putting antibiotics,
Hmm.
various different type of antibiotics, or even painkillers directly into the bladder, treating the source, because we know the bladder does not absorb those chemicals. And so you don't get the side effects. So if you have a treatment that helps you, even if it's 30, 40%, with no or minimal side effects, actually for our cohort of patients, that is a win. That
Hmm.
is such a win, because
Agreed.
otherwise they are suffering at home and completely, and often in cases, bedbound and
Hmm.
unable to get out.
Yeah, I couldn't agree more with that. It's really important to also talk to the patient to find out what they're interested in and what they would like to do. And it's different for every patient that I talk to. So, can you walk us through what it actually looks like to take Uromune with regard to the dosing, how long you take it, and how it might
Yeah,
fit around other
absolutely.
medications?
Absolutely. So the nice thing is, looking at our long-term data, and I'm proud to say we have used Uromune in the UK longer than anyone else, and we've been very meticulous in following up the long-term data for this.
Hmm.
There has not been any interactions with medications, and that makes sense, because what you're doing is placing dead bacteria in the mouth, right? There's nothing going into the liver to be synthesized to turn into some sort of pro-product.
Hmm.
Actually, it is very much a immunity-driven product. How you take it is you spray it under the mouth, two sprays under the tongue, and you hold it there for 2 minutes. Previously, we used to say, hold it and not eat or drink for an hour before and an hour after. So my patients, when I say, look, get up first in the morning, do 2 sprays, go about your activity. After an hour, go ahead and brush your teeth.
Hmm.
The nice thing is, in the latest data set from the manufacturers themselves, they've realized that actually holding it just for 15 minutes either side is enough,
Okay,
which is
that's much more
game changing.
convenient. Yeah.
So much more convenient. So nowadays, it's essentially you say to them, look, 2 sprays on the tongue, hold it for 2 minutes, and then wait 15 minutes before you go ahead and brush your teeth and do
Hmm.
your activities. That is just a normal day. It
Yeah.
takes 15 minutes for most people to wake up, you know. So actually, it is much easier to use. In terms of storage, you've got to keep it cold. And I think that's
Hmm.
one of the problems from the manufacturers is when they want to try and ship it to around the world, that cold chain is
Hmm.
essential, trying to keep it cool. However, if you think about what it is dead bacteria. As a product, it is very, very robust.
Hmm.
So I'm very proud to say that we've been being able to offer it to lots of patients from around the UK and around the world who come collect it from us and can transport it back quite effectively and safely, even though they don't technically have a fridge that they carry on the plane with them. There are certain ways you can do it, and that's very, very important to say.
Yeah, it is helpful to know that. We have heard from quite a few patients who have traveled to find Uromune in different countries, and the UK is one of those main countries that they travel to.
Absolutely, and I think that's another thing to mention. Uromune is not licensed in the UK, and that is a shame. And that is something that will take time because
Hmm.
things do take time. However, there are certain countries where Uromune may be used more often. I just always have to give that caveat. I won't name the country itself, but there is a South American country where Uromune is sold a lot, something sold a lot. But if you look at how much they actually ship and import from Spain, they sell more than they import.
Hmm.
So therefore, you just have to be careful. Some things that are too cheap sometimes actually may be, unfortunately, a fake product. You can imagine people who are really suffering and desperate to find it, people will take
Hmm.
advantage. So yes, you can get it from around the country. Yes, people do travel the world to get it, but always just double check it is a reputable source because that is very, very important. And I think, in general, people who treat UTIs, let's be honest, are mainly GPs, right? GPs will see
Right.
the vast majority or pharmacy first in the UK.
Hmm.
But the complex UTIs, the recurrent UTIs, there's not that many, I would say, experts, people who see it day in, day out.
Agreed.
Actually, most people who see it are general urologists or general
Yeah.
urogynecologists. I think that is a shame. And I'm proud to say that in our clinic, myself and Steve Foley, we have had a lot of experience in it. And I hope, therefore, our patients feel we give them a much better care and a more holistic care because of that reason.
Yeah, and I'm sure they feel that way. This is the reason that we try so hard to identify those types of clinicians that are specializing in UTI because patients find it so difficult to find good care. Back
Mm.
on the taking Uromune, you mentioned that it doesn't have interactions with other medications. Does it have any side effects itself?
Yeah, so the side effect profile has been really, really good in the sense that over 90% of patients have zero side effects. So they've taken it and they have no reaction at all.
Hmm.
For those who have had reaction, they will very minor. You've had some people who get a runny nose, a sore throat. Sometimes people get acid reflux. The people who are allergic, inverted commas, to the product, who develop hives and stuff, we do,
Hmm.
do want them to report to us if you have anything like that. We will report to the manufacturer straight away. But if you look at it, it's the people who probably are allergic to the glycerol component of the
Hmm.
vaccine, suspended in glycerol. And I think that probably is the allergen that's triggering it because the other bits are basically dead bacteria.
Hmm.
Dead bacteria are everywhere. In fact, in the patient's bladder because they have recurrent UTIs.
Right.
It's mainly just the glycerol component I think people are probably allergic to, and it's a very, very small proportion. If that is the case, the key is to stop, let your clinician know. I mean, when we prescribe it in the UK, it's a named patient basis. That
Hmm.
means we as a consultant take overall responsibility. It's
Hmm.
not the GP responsibility. It's not the local urologist's responsibility. It is our responsibility for this drug. So
Hmm.
for us, we really want to know if you have a side effect because we want to get it better. We want to get it improved. We want to deal with it ASAP.
If you do start taking Uromune, how do you know it's working? Do you have symptom improvement, or is it just that you don't get as many UTIs in the future?
It's both actually. It's both because it's not just about the number of UTIs. I think if we bring a woman back to her baseline, let's just say the average woman in a community, you
Hmm.
will still get, unfortunately, at risk of one UTI a year, for example, 0 to 1.
Hmm.
That is just baseline, and that is part and parcel. But that UTI should be cleared, like in 2/3 of patients, with just water and good hydration. as opposed to relying on courses and courses and courses of antibiotics. And even you still have UTIs, what we want to see is the severity of the UTIs decrease. So UTIs where previously taken 10, 14 days of antibiotics to clear, now responds within 5 to 7 days. That is such a win, because if you can limit the amount of antibiotics you require, that can only be a good thing for the patient. That is really our aim, is to try and preserve antibiotics for those who really, really need it where possible.
And so, I mean, that's interesting when you say baseline. The baseline for me, for instance, was if I ever had a UTI, I could take 3 days or 5 days of antibiotics, then I just wouldn't get one for years. So that would be my baseline. And I suppose that's where people go back to rather than having to take so many
And
antibiotics.
absolutely, I think a lot of our chronic UTI patients, if they got back to that situation, they would be over the moon,
Ecstatic,
right? They would
yes.
be absolutely ecstatic. So I think, when we have a consultation, we never say to them, you will be UTI free forever. That is not realistic. We have to
It's
be
not.
realistic with the patient. However, it's about, as you correctly point, Melissa, it's about quality of life. We want to improve your quality of life, and that might be decreasing the number of UTIs, but also might be decreasing the severity and decreasing and improving the response of the UTIs to standard treatment.
And how long do the benefits of Uromune last?
It's a very good question. So when we first looked at it, we realized it probably lasted about 2 years or so, sort of 14 months, 18 months, and then people needed a top-up dose. Then that little virus in 2020 called COVID, unfortunately came and destroyed everything. We had to restart all of our trials and data. But when we then restarted in 2024 and we looked back at data, we realized some patients actually had good efficacy for up to 9 years. 9 years since we started the process, now it's year 10. What's interesting about that is it's not you take it once and that's it, you're forever cured. Actually, there are patients, quite a lot of them, who after a few years will need a second dose. And actually, for them, they don't wait until they're in a severe situation. They'll wait until they get 1 or 2 UTIs and then they come back for it, as opposed to wait when they're already in the non-stop antibiotic cycle, that doom spiral, they say, before coming engaged again. And they seem to have quite a good long-term efficacy in that respect.
You mentioned that in the UK, Uromune is available in a named patient program. Can you talk us through what that means and how the steps work and how long it takes?
Yeah, so it's actually a very quick process. Name patient basis means, look, you have a drug that is potentially very, very helpful for patient, but it has not gone through the formal licensing processes in the UK, the official process of make it a licensed medication. However, consultants having assessed the patient, and that's the key, we cannot just do it without either a telephone call or a face-to-face consultation. Assess the patient, go, you have been fully investigated, you are suitable for this, you can then take it. And actually, the process, once we do that, the paperwork is actually very straightforward. And most of our patients, if they come to our clinic, for example, can collect it the same day and go home with it. So it's a one-stop shop. That is the key. But at the same time, this is also why it is not readily available. You can't just send a prescription and give it to a pharmacy and they
Right.
order it for you. That is not going to work. So that's the key. It is essentially, I have identified a patient. I think it will be very beneficial for them. I've weighed up the risk and benefits and I take responsibility and then I prescribe it for them.
It also means that patients have to pay for it privately, right? And that the NHS is not currently funding it. What are your thoughts on whether the NHS should?
So there are a small handful of NHS trusts in the UK now who have managed to get it onto their formulary. But again,
Okay.
I'm very pleased to see that. Unfortunately, in those trusts, you will see that they have to go through really quite rigorous criteria before they get there. So, for example, they would have failed organ therapy, bladder insulation therapy. You have to have the 4 pathogens only, not the other pathogens, which, as we already talked about, is not obvious, not clearly evidence based at all. And only those patients may get it. They may only be able to give, say, 10 or 20 per year. So very, very heavily
Okay.
limited. But my phrase against that, which I think is where Uromune should sit. I think Uromune should sit much earlier in the pathway. In fact, if anything, we should sit it almost in primary care for the GP to prescribe and not wait till they get to a consultant in urology. And why do I believe that? Well, look, if you think about these new weight loss jabs, right? This is one of my latest analogies. Everyone loves Monjaro or Ozempic and all those
Yeah.
sort of things that you do lose weight. Now, if I Ozempic a lady with a BMI of 60 and she drops her BMI to 40, by clinical definition, she is still morbidly obese. And so by trial basis, we have failed. Does that make sense? Actually, you've missed the boat. if we were giving them, and we shouldn't be, this is obviously part of licensing, but you should target them earlier, before they've got to the
Hmm.
embedded chronic stage. You should target them when they're still getting good breaks between these acute episodes
Yeah.
where the immune system could still clear it. That's where I think it really should fall. And I really hope one day that actually, when it's fully licensed, that's where in the pathway I will be championing for it to arrive. Not at the end as a last resort, which is currently what we're doing for a lot of patients because
Yeah.
actually they have nothing else, much earlier in the pathway to try and stop them getting to the severe stage.
It would be great to see fewer people making it to that point because right now we just
Mm.
have thousands and thousands of people in the UK already at that point and not being able to find these solutions. But like we
Absolutely.
were talking about earlier, it's not available in a lot of countries. So we often refer people to your clinic from different countries or to get in touch to see if they can come and speak to you about Uromune. What would be the process for an international patient to access Uromune via your clinic?
It's the same as any other patient. So they can book a telephone consultation. We'll obviously account for the time difference when that happens. Please
Hmm.
make sure we tell them to send us all the medical information. So I, myself, and my colleague, Mr. Foley, will be able to assess it. And then
Hmm.
we make an assessment at that over the phone. Is this patient suitable? And in most cases, they are, in which case they will have to come to our clinic somehow, collect it in person, and bring it back. And we will obviously support them in that process, but also the documentation to get it across the border, because obviously this is the medication, but
Right.
it is their medication, so there should not be a problem. No, so we will certainly support it. What we are not going to do, and that's very important, is that we're not going to be shipping it across borders, because actually that is unfortunately not allowed. We can ship it to the patient in the UK, we can send it that way, but not across borders. But yes, wherever the patient is, the key is they must have an assessment first. They must
Hmm.
have a formal assessment with someone who knows what they're doing to make sure they're suitable, and also make sure we're not missing something. Because
Right.
unfortunately, there are, if you have a massive kidney stone, if you have unfortunately small
Hmm.
bladder cancer, without treating that, you're missing something much more important.
That makes sense. And we briefly covered this earlier about other types of vaccines. In Europe, in particular, there are a few available, such as Urovaxom and Strovac. How do they compare to Uromune in terms of their efficacy and their mechanisms?
Yeah, absolutely. So we'll talk about Uravaxon first. So that's a tablet, an E. coli conjugate tablet. It's good. In fact, funny enough, I have a few patients. I saw a patient only last week who got it
Hmm.
from Korea, from South
Hmm.
Korea, and she had some good effect on it. It is not as efficacious from the data as Uromune, and I think that's
Hmm.
probably because, as we mentioned, you need more than one bacteria to get that broad spectrum immunological response. The other thing with it is that it's a tablet. So therefore, the patient, whoever it is, has to be able to swallow tablets. They
Hmm.
cannot take it as a spray. As a spray, it means people with swallowing difficulties, even children, though
Right.
that's very off license, but we have used it in children, have with them some very good effect as
Hmm.
it happens. Um, they're more likely they can use it. The Strovac is the vaginal suppository. So again, that therefore means you can only give it to someone with a vagina. So therefore, the men with UTIs and the men with
Hmm.
prostatitis, or the children, you shouldn't
Right.
really be putting things up children's, vagina for obvious reasons.
Yeah.
Limits it. Strovac White has much less data available. It's very much earlier on in the pathway, but
Hmm.
evidence is coming, and it needs a booster after a few months as well. So, but all of these things, if it works, if it gives benefits, absolutely, we should definitely embrace it because our patients are desperate. So long as it's safe and efficacious,
Hmm.
why should we not be giving it to our patients?
It's been great to see the conversations around UTI vaccines growing a lot. So patients are becoming more aware of it and trying to find ways that they can access it. And clinicians are starting to ask more questions about it as well. So that's also good to see. I want to talk with you a bit about UTI diagnostics because that's a really important piece of this puzzle
Yeah.
too. We're kind of pretty aware in our community about the limitations of standard culture, but can you cover those and also how you get around that in your practice?
Absolutely. I mean, diagnostics is so important, right? Because if we can diagnose a problem, if we can get the answer, we can get the treatment. All right. So diagnostics is key. And unfortunately, as we all know, again, preaching to the converted here, dipstick and culture is useless in a lot of cases, right? Dipstick is so poor when it comes to rare pathogens. Great if you have E. coli, but you
Hmm.
have to make sure the urine is concentrated in the bladder, it has had time for the nitrite conversion to occur. If you have enterococcus, for example, you'll often only get 1 plus leukocyte or nothing, a clear dipstick, even though you have 10 to the power 8 of enterococcus
Hmm.
swirling around the urine, because it does not change the leukocytes and nitrite. It's a non-nitrite converting organism. So dipstick itself has really fallen out of favour. Culture, yes, that's fantastic. Smear it on the agar plate or put it in Eppendorf and run it through one of the new machines, and they will see whether anything grows. But that's the problem. It has to grow. So if it doesn't grow, for example, because the patient is on antibiotics, you get no growth. Or if the patient has drank a shed ton of water, loads and loads of water, and diluted the bladder, you will get a level below the cutoff. So you get something called no significant growth, when actually, had they not drank so much water, had it been more concentrated, it would have been a significant level. The other problem you have is something called mixed growth. Prior to this, back in the days, mixed growth was seen as only from contamination. It's because you didn't collect it properly. That's why you have mixed growth.
Yeah.
More and more now we realize mixed growth is significant. If you look at a plate of mixed growth, my word, it is quite spectacular. It's important we know what organisms are in there. And I'll give you an example of one later on, actually, if you would like to. But that is the problem with the culture itself. The other problem with culture itself, which I think your community really understands, is the biofilm or the embedded infection. So if it's embedded, if it's intracellular, you will not pick it up in the urine because it just floats around the urine. There's nothing in the urine, it's in the cell. So unless you can take out a guy's bladder and mush it up, you will not be able to detect it. And actually, Professor Jenny Rowe, for example, with her organoids in UCLH, has really shown just how important this is, because you can treat the urine, it's completely clear. But when you take out the fake bladder, they're called organoids, which Eleanor Stride and Professor Rowe has really been championing, and mush that up and test the urine, the supernatant from the mush, the bacterial levels are off the scale. That's where they are, and yet we don't do that. Biofilms, the other problem with that is when it's in a biofilm, the bacteria is trying to stay alive. So it falls asleep, is the sort of easy way to think about it. It hides and sleeps. And so if you put a sleeping bacteria in culture, it wouldn't grow. You've got to wake it up. You have to do an enhanced long-term culture. You might have heard these terms about enhanced cultures. You've got to really leave it long enough for the bacteria to start growing. That's why so many are missed. And that is the problem. When you do get a positive culture, it is amazing. It is so useful. It is absolutely key. But just because your culture is negative does not mean you don't have an infection. I think that is really important. And so many patients have suffered because they say, urine is negative, off you go see psychiatry or go see the chronic pain team. And that's a never-ending cycle. So how do we change that? Well, that is the million-dollar question, isn't it? And we're very proud. I'm very proud to say that I've been involved with a company called Lucerne Scientific, and we're bringing essentially molecular-based tests. And you would have seen some of these molecular-based tests. For example, Microgen DX in America and Texas, they were one of the earliest adopters. You send off the urine, they charge an absolute fortune, and about 2 weeks later, they give you an absolute massive panel of different bacteria. But that just shows if you do a molecular, so PCR, DNA, or RNA-based test, you can pick up so much more. They pick up probably a bit too much, and it takes too long. What we're trying to introduce is a device which, if you put the urine in 35 minutes, it will tell you if it has the top 6 uropathogens at a significant level. So therefore, missing all the tiny minutiae only at a significant level. And because it's DNA-based, it doesn't matter how much antibiotics you've had, you're detecting bacteria, you're not looking for growth. For me, that is the future. We must change our diagnostics. We must embrace new technology in order to help patients. And I'll just say about that example. Great example from 2 months ago, actually, and it's really struck me, is this poor lady has had nitrofurantoin, trimethoprim, cefalexin, what was the other one, fosfomycin, and her coaches have come back, mixed growth every single time, came to me in the clinic. We ran it as one of our point of care tests, and lo and behold, 3 pathogens came up, one of which was Pseudomonas. Put her on some ciprofloxacin or quinolone, and suddenly her symptoms resolved. If we know the bacteria, and this is key, if we know the bacteria, we know how to treat it. For example, Pseudomonas only really responds to quinolones and gentamicin and that sort of stuff. So you give them anything else, it's useless. If you have someone with, say, Proteus, and you give them nitrofurantoin, it's useless because it's 100% resistant. Yet nitrofurantoin is our first line for UTI. So every single Proteus patient gets neglected. If we know the bacteria, not only do we empower the patient to say, you have a bacteria, you have a UTI, but also this is likely the best antibiotic to treat it. that is a game changer. And that's what we've been very proud to say we've introduced in our clinic.
And I think it's a really important approach to move into different technologies that can detect different organisms. But that raises the question of how the 6 uropathogens were selected and if that was based on historic urine culture data, because then weren't we maybe missing things?
Really, really good question. So believe it or not, as a clinician, people know, oh, antibiotic resistance rates are rising, right? And when I started my role here as the clinical lead for functional, I said, well, look, that's great. Can you show me how bad it's rising? There are no data. There's no
Mm-hmm.
antibiogram for uropathogens. That is ridiculous. You would have thought there would be, right?
Mm-hmm.
So actually, as part of my research with Professor Analyst in Oxford, we looked at every single positive urine culture in Berkshire over
That's a
3
lot.
years.
Mm-hmm.
That's a lot, right? There were in 2023, for example, there were 20,000 positive cultures, 180,000 culture tests. That was a lot of data to go through,
Mm-hmm.
and created an antibiogram which we're presenting at international conferences, which shows exactly the percentage resistance of each uropathogen to each antibiotic. And then we also know which ones are being detected, which ones are not. Presuming that all things are equal, we then get proportionally, we know how many are being detected and how many are missed. And the top 6 uropathogens covers more than 93% of all pathogens, which is fantastic. Whereas if we just rely on culture with all the limitations, and when we do the analysis, the accuracy rate can drop even to below 60%, which is shocking.
Mm-hmm. It is shocking. This is why we have the problem with so many patients not finding care or just being turned away, like you said, sent to psychiatry, told it's all in their head. What do you do in cases like that if someone's test comes back negative, but you're sure they have a UTI?
Look, from my perspective, if you give someone, say, antibiotics and the symptoms resolve or improve, it really must be a bacterial component, right?
Mm-hmm.
Because antibiotics are not anti-inflammatory, they're not analgesic, they literally just kill bacteria. So that is already something you need to, you should listen out for in your clinical
Mm-hmm.
consultation. I think most of the time, for me, it's just letting the patient talk and believing them, empowering them. Because yes, and Hannah, we all know there are a small cohort of patients where actually it is a psychological issue. There is certainly that component there, but that is not every patient. We should not brush that for every single patient. Every single patient, we should give them the opportunity to talk and do the appropriate test. And this is where the new molecular test comes back. Your urine culture might be negative because you cannot get off low dose antibiotics without a massive flare up. So let's run it and let's run a digital test. Let's run a molecular test and find the bacteria, see what we're dealing with, and take it from there. I think a lot of this is about believing the patient.
Mm-hmm.
Just because your cystoscopy is normal, your ultrasound is normal, doesn't mean you don't have a bacteria. All
Yeah.
that means is you don't have a risk factor that we can identify for UTIs, which is great.
Yeah.
It just, however, it still means you need treatment for your UTIs. It's about believing the patient. I think that is really important. I mean, can you believe we don't even have a term for chronic UTI? Right? We know
I
what
was
the
just
acute
talking
UTI
about
is,
that this morning.
right? We have an acute UTI, we have recurrent UTI. What is a chronic UTI? There is no definition for it. Isn't
There
that
really needs to
ridiculous?
be one. Yeah, exactly. Well, we also hear from patients who have a different species that shows up across multiple tests. So every time they test, there's a different organism. What do you think could be happening there?
Yeah, very, very interesting. And the answer is this is where the urobiome people are really coming into play.
Mm-hmm.
We know the urobiome and the changes in the bladder can occur within 12 hours. So from a asymptomatic to symptomatic, if you do a molecular test before and after, you can have a massive change in the different species in
Mm-hmm.
the bladder. We don't know why, we don't know what's protected, we don't know what's normal, what's not normal, but we know the changes are there and it is detectable because imagine, remember maybe 20, 30 years ago, urine was sterile. Do you remember that?
Mm-hmm.
That is now completely out of the window. So we can sort of detect it, we just don't know how, unfortunately, to interpret it. However, I think, and this is, I think, really important, there must be some form of biomarker, and this is what we're looking into research-wise, there must be some sort of biomarker in the urine, in the tissue, in the blood, that is activated when there is a significant urine infection. So irrelevant of what bacteria it is, it would be great if we had a test, for example, where if that biomarker was active, you know they have a UTI.
Mm-hmm.
That would be, again, another game changer. Again, that is diagnostics. It is all about diagnostics. We
It
need
all
to know
comes
what
back
we're
to
dealing
that.
with.
Mm-hmm. Yeah, the biomarker conversation is quite an interesting one, and I've had that with a few different researchers. A point of care biomarker test would be very interesting and helpful for patients. If you could
Exactly.
change one thing about the UK healthcare system and the way it deals with UTIs, and you could change it right now, what would that be?
There's so many things, so many things. I think my biggest frustration is our constraint due to funding and due to space constraints and limitations.
Hmm.
If we could, I'm very proud of the service I've set up here at Royal Berkshire, but also in the Forbury Clinic privately. I'm very, very proud of what we can offer our patients. But we are one clinic in one area of the UK,
Hmm.
limited. Therefore, we would love to be everywhere. We would love to run many, many clinics, but limitations of cost, limitation of finance is gonna be what hampers it. The other thing was quite rightly, regulations in the UK take a long time and
Hmm.
are rigorous, right? Because women have suffered. And look at the Cumberledge report. Women have suffered from the mesh,
Hmm.
from all those sort of medications that no one believed them for. So it's
Yeah.
quite right. The UK system is rigorous, but it is slow.
Yeah.
It is slow, and we all know that. And that is unfortunately a frustration.
Things can never happen fast enough for patients living with this kind of discomfort and the quality of life impact. How can patients get in touch with you if they'd like to come see you at the Royal Berkshire or in your private clinic?
Yeah, I mean, Royal Berkshire is NHS, so obviously if you're a Berkshire patient, please get a GP to refer to me. They will triage you to my clinic and we'll be happy to see you very, very quickly. Slightly more difficult when you're out of area, as you can
Hmm.
imagine. For the private sector, just contact the Urology Partnership or the Forbury Clinic and find us, drop us a message, and we'll definitely engage with you as soon as we can and see you then. For us, it's all about offering a really comprehensive package, and we really hope for patients who have previously been told there's no other hope out there. Actually, we hope that we can offer some hope for you. And even if it's, as we said at the beginning, Melissa, even if it's a 30-40% improvement in your symptoms, a
Hmm.
lot of the patients are delighted by that because compared to the current status quo, it is a complete game changer.
Agreed. And hope is so important on this type of journey,
Mm,
trying to find a resolution for your symptoms. I'll make
mm.
sure the links to the two are in the video description so people can find you easily. And I just want to thank you again so much for sharing these insights.
It's my absolute pleasure. It really is great that you are championing this disease that affects so many patients, women and men, yet is so commonly neglected in the UK and around the world.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.